And, I'm curious what your criteria is for in-office fulguration. What kinds of tumors are you fulgurating versus what kind of tumors are you saying, hang on, we should go to the operating room for this?
Yeah, so I would only do it for patients that have a known history of low-grade tumors in the past and have a tumor, again, that looks low-grade. We will typically send, I obviously won't have the cytology results at the time, but we'll send cytology as well to ensure that the tumor that appears low-grade actually is low-grade. But a patient that has a few, not someone that has like an entire bladder full of tumors, but a few tumors, I'd say they all need to be certainly less than a centimeter. Those patients, again, with a history of prior low-grade tumors, I would be willing to do fulgurations. If when we have them come back for their next cysto in 3 or 4 months, their bladder has exploded and has a bunch of other tumors, then I think we have a conversation about when to actually go and do biopsies. Occasionally, we'll do small biopsies in clinic too, again, just with the urethral lidocaine and cauterize after. But I think, again, someone that's had a history of really just low-grade tumors, if it has that appearance, either surveilling them or offering fulguration is reasonable.
Yeah, you mentioned that you do in-office biopsies too, so that may answer my next question for you. But, as you were talking, I was thinking, I wonder what that time frame between tissue diagnosis and, let's say, they eventually get a recurrence. What's the time frame between, the time point, the initial index diagnosis with tissue versus the next time we're going to need to get tissue? You said that you may just take it in the office, you're going to send a cytology, but tell me your thoughts on that.
Yeah, so I think I don't have like a hard and fast absolute cutoff, and some of it, again, is dependent upon a lot of patient characteristics. So our patient, like our 80 and 90-year-old patients with a lot of other comorbidities, where it's unlikely to be something that's really shortening their lifespan, I'd have a much higher threshold for, again, treating this conservatively in clinic versus young and very, but I would say patients that are having really rapid recurrence of tumors every time we're looking in their bladder, we're seeing something. Patients that are having large tumor recurrences, again, a bladder full of recurrences, I think those are reasons that we need to make sure we've had recent upper tract imaging and there's not some lesion in the upper tract that is seeding the bladder, and to get tissue to ensure this really is still just a low-grade tumor that's poses a low risk of progression, and being more conservative is still safe.
Let's circle back a bit to the counseling that we were talking about earlier. The one thing that we haven't touched on yet are the resources that are out there for patients. I personally love as a urologic oncologist, there's advocacy networks for almost every cancer or foundations that have resources online, Urology Care Foundation being one of them. What kind of resources do you recommend to your patients? And also, what do you find that they're looking for? Like, are patients looking for videos, written resources, podcasts? Like, tell me what your experience has been.
Yeah, and specifically for this intermediate risk population?
Yeah.
I would say, my favorite resource for all of my patients with bladder cancer is really the BCAN website. I think that they have really great resources for patients to read, but also all their, like, the patient portals where they can go on and post questions and like read real people's experience about the various treatments, I think is invaluable. And you can spend all day telling the patient what to expect about the treatment, but most of us that are urologic oncologists haven't had non-muscle invasive bladder cancer and actually been through all the catheterizations and cystos. So I think it's easy for us to tell someone what it's like without truly appreciating what it's like. We also, it's starting next month, but we have a bladder cancer support group here that is starting, and we're gonna have like in-person meetings allowing patients to interact with other bladder cancer patients throughout the entire spectrum of disease. And I think I haven't found it quite as frequently in this patient population as the patients with high-grade disease that are requiring cystectomy, that they really want to sit down and have those conversations in person with people. But I don't know that I've actually asked explicitly. I will ask the bladder cancer patients that are requiring cystectomy, because it's such a big life-changing procedure, if that would be beneficial. And I probably am not doing my due diligence and haven't actually asked these patients what they need to make the decisions, but BCAN is normally where I start for most of them.